So greetings and a warm welcome to everyone. I'm Sreyoshi, the SN moderator from Clanet. It is my proud privilege to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate to have the valuable support of esteemed doctors and express my gratitude to each one of you for dedicating your time to be with us today. Allow me a moment to introduce our platform, Clanet. It stands as one of the largest live digital CME platforms in India, providing a space for doctors to create and share medical content. Now, I would like to invite Dr. L. Meenakshi Sundaram sir to take over. Sir holds degrees in MBBS, DA, MD. Sir is Administrator, Dean and DME in Government Medical College, Theni. Sir is Professor of Anesthesiology, Thanjavur and Tirunelveli Medical College. Past National Vice President of Indian Society of Anesthesiologists. He is past National Governing Council member of Indian Society of Anesthesiologists. Sir is past President of ISA Tamilnadu State Branch 2011 to 12, past State Secretary of Indian Society of Anesthesiology, Tamil Nadu State Branch 2006 to 2010. So without any much delay, sir, I would like to hand over this session to you now. Over to you, sir.
Thank you, Clarinet, for continuously supporting us. At the outset, I request our President ISA Puthukkottai City Branch, Dr. Munian, to offer his presidential remarks.
Sir, good evening, sir. Dr. Munian, President ISA Puthukkottai City Branch. Today, we are conducting fourth session of second edition of Puthukkottai Bhudhan on the topic of management of difficult airway. Welcome, Dr. Jeyarani, Dr. Yogasathya, Dr. Raghuvaran. Both all are from Thanjavur Medical College, which I also did PG at Thanjavur Medical College when our academic chairman was a chief for us. And also welcome Dr. Gangadhar, Professor and HOD, Department of Anesthesiology, Siddhartha Medical College, Tumkur, Karnataka. Today, there are three speakers from Thanjavur Medical College, Dr. Bhudhan-Management, Dr. Yogasathya, and Dr. S.Raghuvaran. All are dealing about the management of difficult airway. Dr. Bhudhan-Management will speak on the securing surgical airway. Dr. Yogasathya will speak on the difficult airway guidelines, and Dr. Raghuvaran will speak on the Mallampatti grading. And the whole session will be moderated by our Dr. Gangadhar, Professor HOD, Department of Anesthesiology, Siddhartha Medical, Tumkur, Karnataka. And also happy to share that the Puthukkottai webinar last week conducted on the topic of ventilation strategy by Bangalore Medical College was attended by 795 delegates. Thanks to our academic chairman, Dr. A.L. Meenakshi Sundaram. Let us speak on the speakers' lessons. Thank you, sir.
Thank you, Dr. Munian. So,
you,
my duty to welcome all of you for this Puthukkottai Bhudhan second edition, fourth episode, which is being participated by people from Tamil Nadu. The initial 3 webinars were super duper hit because the minimum attendance was 721. For the other 795, the next one is 821. So it is a good number, and we are happy that our effort is giving some fruit to the young generation, mainly the postgraduates. And last week, as our president pointed out, the ventilation strategies have a good hope of aspiring young anesthesiologists to deal with delicate patients. So in continuation, we are also having the same airway this week also. And I thank everyone for your continuous support. And in this lecture, the Thanjavur Medical College, Tamil Nadu is participating in this. And as a principal, we want a postgraduate to be always there to promote the next level of teachers. They are the next generation teachers. So I welcome the youngest person in this webinar, Dr. Raghuvaran, who did his MBBS in Coimbatore Medical College. And he is currently pursuing his MD in Thanjavur Medical College. So in addition to that, Dr. Yogasathya is participating in this webinar. He is a keen academician. Even in our previous edition, first edition of Puthukkottai Bhudhan, she has participated. That shows her perseverance in pursuing academic curriculum. So, Madam did his MBBS and MD from Madurai Medical College. At present, she is a senior assistant professor in Thanjavur Medical College, and her interest revolves around regional anesthesia, airway, chronic pain, and palliative care. So, in addition to that, she is interested in cardiac care also. So, naturally, she is interested in delivering a airway lecture. So, she has joined us, and she is going to be followed by Dr. Jeyarani, Professor of Anesthesiology, Thanjavur Medical College. Madam did her DA in Thanjavur Medical College, and sometimes the college itself will have some reputation. So the Thanjavur Medical College, she pursued her DA and she joined MD anesthesia immediately in Madras Medical College. So that shows her academic caliber. And in addition, she is a NABH assessor. So our moderator, Dr. Gangadhar, will be interested in that NABH. Madam knows many, Sir knows many NABH assessors. And even when I was a Dean Theni Medical College, I could get NABH recognition for a government medical college first time in country, only with the help of Dr. Gangadhar. So just because it is NABH, I used to recollect that. And Madam has undergone training in basic courses in medical education and advanced course in medical education. And I am fortunate and I am privileged. When she was a PG student, I was working as a professor in Thanjavur Medical College. So I cannot say that I have trained her or she is my student. So it is a coincidence that when she was doing her PG, I was there as a examiner as well as professor for her. So when these three people are there, they have to be moderated by such a great person, because if I want to introduce the moderator, Dr. Gangadhar, who is a professor and HOD of Siddhartha Medical College, Tumkur, it itself will take another lecture. It will take minimum 15 minutes. But usually, I will not say for want of time, I call Dr. Gangadhar. It is not like that. When a person has achieved so much, which can go up to 15 minutes in presentation, it has to be known, because the young people should know how the great people have come up to that stage. So it is mandatory. I will not say Dr. Gangadhar needs no introduction, and no, his achievements should be known to everyone. So this is a platform. See, Sir is a chief editor of Karnataka Anesthesia Journal, the first one. Another one, see, every time he has gradually, by step, he has improved. Like he was the ISA secretary, Bangalore Metro branch. Then he has become a president, ISA Bangalore Metro branch. Then he has become the president, Karnataka State branch. Then he has become a governing council member, ISA National. Then he has become a governing council member of SARC Association of Anesthesiologists. You see, from a city branch, this is how people improve. Gradually, they improve. This should be a message for the youngsters. Another one I want to tell, he's organizing secretary of ISACON National during 1993. Then he has become an organizing chairman for the ISACON National in 2019, again an elevation. That 1993 conference is fresh in my memory for two reasons. One, he has conducted it fantastically well. That is one. Number two, as a postgraduate, I participated in that conference and I scored all India level second prize in the PG quiz competition. I was eligible for first rank, because the first rank was secured by a qualified anesthesiologist. That is meant for only postgraduates. I know that a qualified anesthesiologist also is qualified, but I didn't contest that because he is really good. Now he is in UK. And at that time, when 1993 December, I participated in the ISA National Conference at Bangalore. Uma Maheshwar Rao and Dr. Parameshwara were the quiz masters for me. And incidentally, they have come as examiner in 1994 March to Thanjavur Medical College. So within 3 months, they have come for Thanjavur Medical College. So passing the examination was assured for me. This assured immediately the moment they entered, they asked, hey, how come you are here, sir? This is how I am doing my post-graduation here. So that is a good thing. He has opened up an avenue. So he got my college NABH recognition. Gangadhar is responsible for my passing the MD examination. Indirectly, Dr. Gangadhar is responsible. And see, I could get a certificate because even in my biodata, even now I am saying I have scored all India level second PG because they have introduced a good concept. 1 mark for one question. If you answer wrong, 1 mark will be deducted. See, so the thing is, I have left. For 100 questions, I have not answered 30 questions. That is how I got the mark. So that's a stringent standard he has imposed. So now the Tumkur, Siddhartha Medical College students are benefited. And another one, he has achieved that eminent teacher. He got eminent teacher award in ISA National 2019 conference. He has awarded lifetime achievement award by the Bangalore City branch, by the Karnataka State branch, and South Zone Conference, and again by SARC Association of Anesthesiologists, which was coupled with the International Conference at Kochi. So I was also happy at the time I was delivering oration. So I am seeing Dr. Gangadhar from the Bangalore City branch secretary to the level, to this peak level. So it is his summit. He has many more things to go. So necessarily we have to inform the youngsters like Gangadhar, they should be introduced. And moreover, if you say that you are an anesthesiologist, he is ready to help. He will not reveal his stature. He is very close to Karnataka government. He can do anything in Karnataka. Bangalore, it is at his fingertip. So for me, if you say Bangalore, the address is Dr. Gangadhar. Every time I contact him only. So even now I thought he is the right person to join us in this webinar. So my pranams and welcome to Dr. Gangadhar sir. Sir, over to you, sir, please.
Thank you, sir. Thank you. Sir, very nice to meet. First of all, before I'm starting, only thing, when I heard the name of Dr. Meenakshi, I think even I thought that she's a female. I never thought that it is a male or anything. Like that, I was very, very anxious to know that who is this Meenakshi. So like that, I introduced to the Dr. Meenakshi that occasion and all the things, and our friendship or anything is going on like anything. So with this context, today, when Dr. Meenakshi has told you had to become the coordinator for today's webinar, that's a thing. So automatically with the second thought, I told, yes, it is my privilege to be with Dr. Meenakshi. Even Dr. Meenakshi is not an ordinary personality because this occasion I want to tell you and all the things. So he is a very, very nice personality and is a man of human nature and is a poet. I can call all the things. He's the best, what you call clinician also. So I can say about it. And it is really, I'm very happy to be with today with the Puthukkottai, the webinar session and all these things. Thank you very much, sir, for my nice introduction and all the things. So this is my duty to see, sir. So now we can start the session. Correct, no, sir?
Yes. Yes, sir.
Okay. Sir, I have to introduce or
you can call, sir. Already I have introduced. You can call one by one, sir. First, Raghuvaran, then Yogasathya, then Jeyarani.
Okay, sir. Okay, sir. Okay, sir. So Jeyarani is the last one, I think.
Yes, Dr. Jeyarani is the last one, sir.
Yogasathya is the first one.
Second. He is a PG. Dr. Raghuvaran is the postgraduate.
Today morning only I came to know that even I thought that Raghuvaran probably is also staff or he's also been lecturer or even, sorry, no lecturer post will be there. When we appointed at the science, we were lecturers, then assistant professors, then professors. So it is a privilege to, I think the first session already were delayed, to call upon Raghuvaran for his talk, especially with an postgraduate and all the things. Morning only, Meenakshi has told he is not this thing, and he is going to have a 10 minutes of time. He is from Thanjavur Medical College. This one, I am over to the Raghuvaran for his talk.
Yes, sir. Good evening, sir. Good evening to one and all present here. Good evening, sir. I am going to start about my topic Malampati classification. In Malampati classification, there is the relative size of the base of the tank compared to the oropharyngeal opening in hopes of predicting the difficult airway. In the year 1983, Dr. Sheshagiri Malampati, an anesthesiologist, who is hypothesized that the size of the base of the tank relative to the oropharyngeal cavity could predict the difficult intubation. He found that there is a significant correlation between the class 3 of Malampati and the intubation difficulties. In Malampati classification, the patient is seated in the upright position and open their mouth while maximally protruding their tongue. Classically, the exam is done without any phonation because phonation will decrease the class of Malampati. The original Malampati classification has only 3 classes. In class 1, there is fully visualization of the facial pillars and the soft palate and the uvula. In class 2, there is fully visualization of the facial pillars and the soft palate, and the base of the uvula is obscured by the base of the tongue. In class 3, there is only visualization of the soft palate. In the year 1985, Thompson and Young added a 4th classification, now which is known as class 4, in which neither the facial pillars, uvula or the soft palate could be visualized. We can only see the hard palate. They found in their study there is a significant correlation between the difficult intubation and Malampati class 3 and 4 among the obstetric patient. In the year 1998, class 0 was introduced in Malampati classification, which shows that there is observation of any part of the epiglottis in an pharyngoscopic view. Clinical significance of Malampati classification. Nowadays, the Malampati scoring system became a routine preoperative physical exam to predict the difficult airway. As per O'Leary and Sandishon and Roberts KW study, the positive predictive value is only 33%, which shows the Malampati scoring is a poor predictor of difficult intubation. As per Coherence meta-analysis, which was conducted in 2016, sensitivity and specificity of the modified Malampati test in predicting the difficult tracheal intubation to be only 0.51 and 0.87. Therefore, Malampati test misses nearly half of all the difficult airways, but it's fairly specific for ruling out the difficult airways. Mask ventilation is also a key element of the airway management. As per large meta-analysis, we found that Malampati score had very low sensitivity in predicting the difficult mask ventilation, and it will be only 0.17%. Malampati score can change during the pregnancy. As the pregnancy progresses, there can be a significant increase in Malampati score in the same patient, which compared in the first trimester and the third trimester of the pregnancy. Obstructive sleep apnea has also been correlated with the Malampati score. For every 1 point increase in the Malampati score, there is a 2-fold increase in the odds of having the obstructive sleep apnea. For every 1 point increase in the Malampati score, apnea-hypopnea index also increases on average of more than 5 events per hour. Comparison of the Malampati score in sitting and supine position. Changing the position from sitting to the supine change the Malampati score to be a higher grade. There is a specificity of the Malampati score in the predicting the difficult intubation in sitting position was 33.3% and in supine position was 57%. And we found that the supine position is a better predictor of difficult intubation. As per one recent study, we found that 93% of difficult intubations are unanticipated and 94% of difficult mask ventilations are unanticipated. Therefore, the anesthesiologist must constantly vigilant and prepare for unanticipated difficult airway management. Thank you, sir.
Thank you very much, Raghuvaran. A nice introduction, a nice thing to you. You conclude the things and all this thing. Even we can take it as extensively. It is a wonderful introduction and wonderful things from your side. So probably I think when you were telling that Malampati, Sheshagiri, even I think I remembered, I want to tell you at this junction, last conference, my national conference in 2019 in Bangalore, I want to bring him as a guest for the conference. Myself only spoken to Sheshagiri, Malampati, this one, but he's unable to recognize what are the things and all those things. This also point to be I think, noted or considered here because I tried my level best, but he has not remembered anything about this. So that is another thing. But overall, the nice presentation by you and any discussion, all the things we are going in the and the last for the discussion for the last. Thank you very much for your wonderful presentation.
Thank you, sir. Thank you, sir.
Now I think we can go to the Dr. B.Jeyarani. I think one is the professor of anesthesiology.
Sir, Dr. Yogasathya, sir.
Oh, okay. Sorry, sir. Sorry. I'm very sorry. Now I think Dr. Yogasathya, who is an assistant professor in the Department of Anesthesiology in Thanjavur Medical College. Now over to Yogasathya for the presentation. Thank you very much.
Good evening, sir. Thank you for the introduction. Sir, am I audible, sir?
Yes, yes.
Hello. Yes.
Yeah,
Yes. My sincere thanks to Puthukkottai Bhudhan, especially Professor Meenakshi Sundaram, sir, for organizing such an insightful and well-structured webinar. Thanks for giving me this opportunity. And thank you, sir, and the team. Let's go to the topic proper.
Dr. Yogasathya, go for slideshow.
Yes, sir. Good evening, sir. This topic is extra multitasking action for our multi-talented anesthesiologist. First, I'm going to tell about take-home message because this is a very important topic. First, we have to fix the few points in our mind before going to the topic. So we have to know when to stop our procedure, and we have to think alternatively according to that, and we have to act according to that. And don't hesitate to call for help. No one will judge you, or no one will underestimate you. So don't hesitate to call for help, and don't hesitate to accept the failure, because failure is a part of a success. And our first and foremost aim is ventilation and oxygenation of the patient, and final to save our patient. So let's go to the difficult heading proper. So what is the purpose of making guidelines and all? It is to recognize the difficulties in decision making during emergency and to assist the anesthetic team in making the correct decision. And it is suggesting the limiting the number of attempts and encouraging the declaration of failure by placing the supraglottic airway devices even when face mask ventilation is possible. Recommending a time to stop and think about how to proceed, and identify the essential skills and techniques with the highest success rate. When familiarity with the equipments and techniques are very important, and acquisition of the new skills and in regular practice, even for experienced anesthesiologists, is suggested by guidelines. Before going to any topic, we have to know the proper definition. So what is the definition for difficult airway? It is defined as the clinical situation in which conventionally trained anesthesiologist experiences difficulty with face mask ventilation and difficulty with tracheal intubation or both. So coming to the difficult face mask ventilation definition as per AAC task force guidelines, it is nothing but so when it is not possible for the unassisted anesthesiologist to maintain oxygen saturation more than 90% using 100% O2 and positive pressure mask ventilation, and in a patient whose oxygen saturation was more than 90% before anesthetic intervention, it is not possible for the unassisted anesthesiologist to prevent or reverse the signs of inadequate ventilation during positive pressure mask ventilation. It is nothing but before anesthetic intervention, the oxygen saturation of patient was more than 90. After the intervention, we cannot maintain the same saturation. This is the definition for difficult in face mask ventilation. Let's dissect the difficult airway society algorithm. This is suitable for all the guidelines, which is for difficult airway. So first part is our plan A, plan B, plan C, plan D, like that. So what is the purpose of those things? That is to maintain the ventilation and oxygenation of the patient. Intubation. So for those things, what are the procedures we are going to do for the patient safety? That's all. So wait a minute, my internet is very poor. So next thing is, what are the types of difficult airway? When you are talking about difficult airway, the first and foremost thing when coming into your mind is anatomical difficult airway. Our main attention also towards the anatomical difficult airway. But we have to know about the physiological and subglottic difficult airway. Coming to the physiological difficult airway, the physiological dysfunction, for example, in critically ill patients, they are having more complications and higher mortality while securing an ET tube in ICU, emergency department, and general wards. We can remember like this as in a non-operative room anesthesia setup. And major adverse events can happen. For example, circulatory instability, severe hypoxemia, and even cardiac arrest can occur. AEC suggests in critically ill patients with reduced functional residual capacity or volume, we can use pressure mode while securing the tubes like in pregnancy, obesity, or ARDS. In case of any suspected refractory hypoxemia or in case of refractory hypoxemia, maintain the spontaneous breathing and go for a awake intubation. And few points about subglottic difficult airway. There are two types of subglottic difficult airway. One is primary and a secondary. Primary is tracheal tumor or any dysplasia or malacia. And tracheal edema, it is secondary one caused by long-term indwelling ET tube or peritracheal surgeries, any scar stenosis due to trauma or ischemic necrosis caused by high cuff pressure. And airway foreign body, regurgitation, aspiration can lead to subglottic difficult airway. And difficulty with cooperation or consent. What are the difficulties in difficult airway is difficulty with cooperation, consent in getting consent for awake intubation, and difficulty in mask ventilation or laryngoscope, difficulty in intubation or supraglottic airway device placement, and difficulty in surgical airway access. And then coming to the intubation difficulty score, the force used for during laryngoscope and time to intubate and what are the number of attempts we are doing and view of laryngoscope and use of external laryngeal maneuver. And what are the confusions while making the decisions? Whether we have to go for awake intubation or intubation after induction in GA, non-invasive techniques for the initial approach or invasive techniques, and whether we have to preserve the spontaneous or abolish the spontaneous ventilation. What are the available guidelines? Many guidelines are available. For example, DAS, AIDA, and ASA guidelines, etc. So before going for the guidelines, we have to go for a preoperative or pre-procedure evaluation. What are the factors we have to identify it? We have to identify the difficulty with face mask ventilation or SAD insertion or tracheal intubation or front of neck access difficulties. So these are all the things. It's not completely reliable while you are doing it preoperatively. And we have to assess for the risk of aspiration. If there is any risk of aspiration, go for a nasogastric tube and reduce the gastric wall. So few test we are going to see about the difficult airway test. This is upper lip bite test. It is a simple one. For example, in case of class 3 upper lip bite test, the intubation difficulty will increase us from 10% to 60%. So this is the 332 examination. That is, the finger should admit interincisor gap 3 and submental space is 3, and in the base of the tongue, it is 2. So few mnemonics are there: bones, moans, lemon, rods, shots. It is for difficulty in base mask ventilation and difficult to intubation, for supraglottic incision difficulty and front of neck access difficulty. So bones is beer, obesity, elderly, no teeth, stiff lung. Lemon, look externally for any abnormalities in head and neck and evaluate 332 rules and Malamati classification, obstruction, neck mobility. RODS is for supraglottic airway devices, restricted mouth opening, obstruction, distorted airways, stiff lungs. And short is for fauna assessment, access, surgery, hematoma, previous any history of radiation, tumor, surgery, and obesity. So Wilson's code. Here we are going to see about weight, head and neck movement, jaw. In jaw movement, we should see for an interincisor gap and subluxation of the mandible, and we have to see for residing mandible and buck teeth. The highest score is highest in difficult airway. So without touching the USG, we cannot complete any presentation nowadays. So USG in a case of difficult airway, we are having 5 views to assess the difficult airway. Suprahyoid for oral space assessment, thyrohyoid for epiglottics identification, thyroid for vocal cord function and vocal cord view, and cricothyroid for cricothyroid membrane identification for cricothyroidotomy, and suprasternal view for ETT confirmation in case of any difficulty in confirming the ETT position. So this is the short video which will explain the ultrasound examination of the airway. They are starting from the suprasternal view. This is the tracheal rings. So we can see the tube position after intubation, and this is a thyroid lobe. We can see the thyroid lobe or any narrowing in the trachea or any compression is there or not, like that. And this is the cricothyroid membrane, which is showing the hyperechoic in the between the cricoid and thyroid cartilage. And one more point I want to stress, this is the sagittal approach of the examination of airway from thyroid cartilage to the cricoid cartilage and tracheal rings. This is a marking of cricothyroid membrane. They are putting the needle underneath the probe. So just they are passing the needle and identify the cricothyroid membrane, and they are marking the cricothyroid membrane in case of any anticipated difficult intubation, or doing in case of unanticipated, or we are going to take a front of neck access, you can mark it in within seconds or minutes. So next one is, this is the picture showing the hyomental distance with tongue thickness. So in case of any shorter hyomental distance, this is an indication of difficult airway. And this is a tongue thickness. If it is more than 6.1 centimeter, that is an indication of difficult airway. This is the picture showing the distance between the skin and epiglottis. If the distance is higher, difficult airway is there. So this is the cricothyroid membrane. This is cricoid cartilage with a single star. And this is the thyroid cartilage. In between those, cricothyroid membrane. So this is the picture showing the thyroid cartilage and cricoid cartilage in between this cricothyroid membrane. This is very useful for front of neck access. So we have to try in the ultrasound examination of airway also. This is the string of beads appearance while examining for the tracheal rings. This is very useful for percutaneous dilatation tracheostomy. So as per target study, the real-time USG guidance improve the success rate of the percutaneous dilatation tracheostomy. So this is a wrong position of the ETT in the esophagus. So we can confirm the ETT position in case of any difficulties. This is the ETT position in trachea. So this is the overall part of the ultrasound assessment of the difficult airway. If the skin to epiglottis distance is more than 2.4, this is difficult airway. And in case of HMD, that is hyomental distance is less than 5.29, it is difficult airway, and tongue thickness is more than 6.1, it is belongs to difficult airway category. So coming to the awake intubation, as per 2022 guidelines, what are the indications for awake intubation? Well, first thing is difficult ventilation, face mask ventilation or supraglottic airway ventilation, or increased risk of aspiration is there, are incapable of tolerating the brief apneic episode and expected difficulty with emergency invasive rescue, directly go for awake intubation without any confusions. UK guidelines for adult in 2019 suggest awake intubation is the gold standard for anticipated difficult airway. So if while doing laryngoscopy in an elective theatre or emergency theatre, after doing a laryngoscopy, you are seeing grade 3A or 3B or 4 of Cormack-Lagan classification. It is called unanticipated difficult airway. So what are the points to note? In case of anticipated difficult airway, ask help first, then complete the ET intubation while maintaining the patient's spontaneous breathing. In case of unanticipated difficult airway, same thing, ask help first, then use the LMA or other second generation supraglottic airway devices to maintain the ventilation. If ventilation is adequate, safest method is to restore the patient's spontaneous breathing. if intubation can be tried again, but the number of attempts strictly less than 3 times. If the ventilation is insufficient or fails, go for a surgical airway. So a few more algorithms we have to see. That is ABS algorithm for management of difficult airway by Professor Mauha. It is a simple, safe, effective, easy to train and to be promoted. That is A for asking for help, B for maintain the breathing, and S1 for spontaneous breathing, and S2 for stap cricothyroid membrane, and S3 for surgical airway. So this is airway management in trauma. You have to remember in trauma, we just start with the BLS maneuver if patient is hemodynamically unstable and pre-oxygenate the patient, do RSA, cricut pressure, and Mills. Mills is manual inline stabilization in case of suspected cervical spine injury, and do laryngoscope with McCoy, and oral intubation with gum elastic bougie or introducer. If it is success, okay. If it is failure, go for intubating LMA or cricothyroidotomy. That's all. Coming to the 2022 ASA guidelines, the ASA introduced the guidelines in 1993. It is updating every decade to improve the management of difficult airway. It keep on insisting about the number of attempts. That is 4 times are different with different devices and different techniques to avoid injuries and complication. There is no use of using the same technique and same devices. So you use different devices and different techniques, and completely change the thinking of intubation first and intubation repeated. This point should be erased from our mind. Don't you should stop your urge to intubate first. Okay. In unanticipated difficult airway, ventilation should be maintained while asking for help. This is very important. And SAD should be used to maintain ventilation as soon as possible and try to make the patient return to spontaneous breathing, or even waken up the patient is very safe. And repeated intubation should be avoided. What is AIDA and ASA suggest? It suggests no DSET, that is apneic oxygenation method, nasal oxygen during effort securing a tube. It is simple one. We are just giving a catheter through the nasopharynx and continuously giving the oxygen 15 liters per minute. That's all. And thrive. This is a special equipment needed for thrive. Transnasal humidified rapid insufflation of ventilatory exchange. This is the thrive setup, and supplementation of oxygen throughout the process. Even for difficult or normal airway management is very important. And optimum pre-oxygenation and nasal insufflation is very, very important in all apneic patients while calling for help and in between the intubation. That is, if intubation is unsuccessful. Use whenever is available for pre-oxygenation, during induction, and after giving muscle relaxation to provide apneic oxygenation until definitive airway is secured in case of difficulty airway. And it will prolong the safe apnea period, and difficulty or any failed intubation to be done in an unhurried manner if you are following the apneic oxygenation, and not more than 3 attempts at tracheal intubation and 2 attempts at SAD incision. If fails, if provided SpO2 remains more than 95%, intubation should be confirmed by capnography. So coming few points about apneic oxygenation and safe apnea time. As I have already told, it is very important to follow the apneic oxygenation. It is easy and effective, and extend the duration of safe apnea time. And it is with the optimum pre-oxygenation, and also airway patency is very important for this technique. And it strongly, the guideline strongly recommends to use the apneic oxygenation not only in unanticipated difficult airway, but also during all the intubations. So few points about pre-oxygenation for the sake of our postgraduates. 20-degree head up unless otherwise contraindicated is mandatory, and minimum of 3 minutes with tidal volume breathing, and it should be prolonged for 5 minutes if mask leak is present, and nasal cannula with O2 supplementation with face mask ventilation is very good technique, and 8 vital capacity breaths for 60 seconds, and it is more effective, and target end tidal oxygen should be more than 90%, and you can use CPAP of 5 to 10 centimeter of water if not contraindicated. This is the significance of pre-oxygenation in a different age group and different categories of patients. For example, in healthy adult, even they are smoker, the safe apnea period is 6.8 plus or minus 1 minute. But in healthy adult who are not pre-oxygenated, the safe apneic period is very much less, that is 0.5 to 1.5 minute. In pregnant patient with adult, 2 to 3 minutes. That's all. So this is the importance of oxygenation. Mask ventilation. These are all the points where we are going to follow in the difficult airway algorithm. So we are keep on insisting those points. Mask ventilation is with 100% oxygen after induction, between attempts, and if it is inadequate chest rise during mask ventilation or any obstruction, airway leak around the mask, change your techniques and keep the mask in double-handed technique and do triple manual like chin lift, jaw thrust, like that, and use correct size and correct fitting mask, and you can use oropharyngeal and nasopharyngeal airway to open up your nasopharynx. And optimize the mask ventilation. You have to increase the depth of anesthesia and you have to give neuromuscular blockade, and failure of oxygenation must be identified. An alternative method of oxygenation should be implemented without any delay. Predict a difficult airway in case of failure of mask ventilation, insertion of second generation SAD, and primary technique for maintaining the oxygenation. So these are all the second generation of SAD except first one. So this is very useful in case of difficult airway. And sniffing position, pillow under the 10 centimeter thickness under the head is very important. Contraindication in case of suspected cervical injury. In case of obesity, place a blanket, towels below the scapula or shoulder nape of the neck until the external auditory meatus coming equal to the sternal angle. This is called ramped position, and it is also called as head elevated laryngoscopic position. So what is AIDA and ASA? Insist it is a blind tracheal intubation through SAD is not recommended, and if SAD incision fail, one final attempt at mask ventilation should be tried after ensuring the neuromuscular blockade. And complete, when we are calling it as complete ventilation failure, it is failure to intubate the trachea and inability to ventilate the lung by face mask ventilation and perform emergency cricothyroidotomy. And difficult air, it is suggesting to document every difficult airway and should be filled in the difficult airway alert form. And it also provides suggestion for content of the difficult airway. This is the contents of the, this is a difficult airway code as per guidelines. And a few points about RSA to prevent our aspiration risk patients. The force of 30 Newton is applied in a case of RSA, but in conscious patient 10 Newton, that is equal to approximately 1 kg is applied. Then after losing the consciousness, we can increase to 30 Newtons. If it is correctly applied, it is improve the view on the laryngoscopy. If it is poorly applied, it will be very difficult to view, and also mask ventilation or SAD insertion. So what are the external manipulations we are using during difficult intubation? That is OELM, optimal external laryngeal manipulations. It is adjusted by our anesthesiologist and maintaining by our assistants, and PERP will be done by our assistants, backward, upward, rightward pressure. And the choice of induction agents, it is depends upon the clinical situation and patient condition. So propofol, commonly propofol suppresses the laryngeal reflexes, and with midazolam, it will give better intubation condition and adequate depth during repeated attempts at intubation to prevent awareness. A neuromuscular blockade results in apnea and abolishes the laryngeal reflexes, improves the chest wall compliance. And during RSA, succinylcholine or recronium can be used, and recronium at the dose of 1.2 mg per kg can be used. It is equivalent to our succinylcholine. And the mind management is very, very important while managing the difficult airway. So first attempt at intubation is difficult. Change your plan and change your mind during subsequent attempts to improve the chance of success rather than repeatedly performing the maneuver, which has failed. So pre-shaped stellate, gamma elastic bougie used to facilitate the tracheal intubation in Cook's modification of Cormack-Lagan scoring 2B or 3A laryngeal view. In case of 3B or 4 direct laryngoscopic view, blind insertion is not recommended. It may lead to trauma. So coming to the visual cognitive tools, that is cognitive aid, we can remember a few things while you are seeing in the pictorial representation. So this is a combination of DAS guidelines, that is plan A, B, C, D, and vortex approach. A is intubation, B is SAD insertion, C is face mask ventilation, T is cannot intubate, cannot oxygenate condition, which may end up in a needle or surgical cricothyroidotomy. So as I have already told, the manipulation we can use head and neck manipulations, larynx devices, and plus indicates we can use any adjuvants to facilitate our intubation. And the other triangle and square or indicates different size and type of the instruments we are using. So we are starting from the tube and end up in the needle, that is cricothyroidotomy, and we should adequately maintain our muscle tone. That's all. This is the ready, set, go vortex approach. So you are identifying that we are dealing with the difficult mask ventilation and difficult intubation. So your saturation is 90%, rapidly deteriorating saturation. So you should ready, call for help, and allocate the procedural kit at the bedside. And set is open the kit and prepare the equipment, identify the anatomy. Before going to the go status, ensure best effort all three lifelines like our intubation, ET2 and SAD and mask ventilation. After that only you have to initiate your neck rescue. This is ready, set, go scenario. This is the picture. This is a tabular column which I have already explained it. And this, again, difficult airway algorithm society. It is developed at released at 2015. This is plan A, face mask ventilation. Laryngoscopy is failed. Go for a supraglottic airway devices and final attempt for mask ventilation and go for the cricothyroidotomy. All the guidelines, all the algorithms are same, except a few things are added. That's all. Okay. Let's see those guidelines, each and every plan in detail. There's a plan A, maintain the oxygenation is very important, and head up position and ramping is very important, and pre-oxygenate the patient, maintain the apneic oxygenation, and all anesthetists should be skilled at the video laryngoscope usage and restrict your attempt with 3+1. That's all. Then you cannot intubate the patient. So you are moving to the plan B. Plan B is our supraglottic airway devices. So failed intubation should be declared if you cannot intubate or insert the SAD. And oxygenation via the SAD, use second generation, maximum 3 attempts at SAD insertion. And also blind techniques through the intubation through the SAD is not recommended. In one guidelines, it is recommended in presence of experienced anesthesiologist is there. So you cannot intubate or insert the SAD or oxygenate the patient. Go for a plan C. If you cannot intubate or cannot oxygenation, you are end up in a plan C. So what is that? Failed SAD ventilation. So it should be declared, and it is important. Try to paralyze the patient, and if you cannot do the thing, declare KICO, that is cannot intubate, cannot oxygenate position, and continue the oxygenation by face mask or apneic oxygenation. Then you are coming into the plan D. And here, front of neck access is declared, and you should ready with your team, and before that call for help. And all anesthetists should be trained to perform the surgical airway. And this is the one of the flavor guidelines in 2022. There are mnemonics called O2 PTIM, that is oxygenation through some way, and position, handling or perp techniques you have to use, and change the type and size of appropriate tools, and introduces like stillet and guides you have to use, muscle relaxant, M for muscle relaxant, and cricothyroid membrane identification. So this is the pictorial representation of flavor guidelines. Green is in laryngoscopic success, and your yellow is going for equipments like video laryngoscope, and orange is our second generation SADs, and red is you are in a danger zone, that is front of neck access, like that. This is another pictorial representation of the flavor guidelines, that is O2, PTIM, SOS. I will explain the SOS now. So it has two skills. One is technical skill, other one is non-technical skills. We have already seen the technical skills. Coming to the non-technical skill, that is, you have to brief and debriefing the episodes while you are managing the difficult airway. What is that? It is SOS, that is stop, state the problem, and describe the situation. Options, invite the input from others, and analyze, understand the causes, and share, communicate, and allocate the task to your team members. So this is the flavors difficult airway cord with the pictorial representation of the each drawer is having pictorial representation and color coding. So IDA is introduced in 2016, management of unanticipated difficult tracheal intubation in adults. All the things are same. They are step 1, step 2, step 3, step 4, like plan A, plan B, plan C, plan D. That's all. It is keep on insisting about a continuous nasal oxygenation using O2 flow at 15 liters per minute. And also, if tracheal intubation is confirmed, use the capnography. That is the main difference in step 1. And in step 2, the same SAD incision, they are using second generation, 15 liters O2, the same thing. And if it is success, wake up the patient. You can intubate through the SAD if provided expertise is available. That's all. If you cannot insert the SAD, go for the rescue face mask ventilation. That is step 3 equivalent to our plan C. This is also insisting continuous nasal oxygen flow rate and also ensure the muscular blockade. If possible, wake up the patient. This is a very important. And if it is not succeeded, it is branded as complete ventilation failure. You should call for additional help. So coming to the emergency cricothyroidotomy, it will be developed by Professor B.Jeyarani madam. So here they're using 15 liters O2 and also perform one of the surgical techniques. Don't forget the post-procedure plan, post-procedure care. Treat airway edema, monitor for complications, and counseling and documentation is very important. And this is the ASA guidelines. So just see any difficulty in laryngoscopy and difficulty in ventilation, any risk of aspiration, any rapid desaturation, difficulty in emergency invasive procedure. If all S is there, go for a awake intubation. If it is no, proceed with intubation attempts. The second step, you are proceeding with the intubation attempt. And here you are going for the awake intubation. There is no risk. So next, if proceeding with the intubation attempts, you are encountering the mask ventilation is adequate, confirm with ETCO2 monitoring. If mask ventilation is not adequate, you have to go for a next step. Here, limiting the attempts and calling for the help in meantime is very important. So, mask ventilation is adequate, confirmed by CO2, non-emergency pathway, you are landing. Then, if mask ventilation is not adequate, consider SAD, the same plan C and step 3 are entering here. What is the important in ASA is, they are keep on insisting about the limiting the attempts. That's all. Limiting attempts and be aware of the passage of time and call for help for invasive access. So if you cannot do anything, emergency invasive airway. So this is a picture showing the infographics, that is patient history, physical examination and cooperation. Clinical context is very important. Clinical experiences and skills are very important. Your available resources with available device is very important. As I have already told, is any difficulty is there, directly go for a awake airway management. Is nothing is there, airway management after induction of anesthesia. That's all. Let's go to the surgical airway by Dr. Jeyarani madam. And thank you very much for patient listening. Thank you, sir and
madam. Thank you very much, Dr. Yogasathya. Really, first of all, I congratulate you for the keep of the time, nearly about 30 minutes. You have caught up so nicely. You take over all the things that make the difficult airway guidelines so easily, even not for the regular anesthesiologist, even for my postgraduates. So, end of your session, they're so confident there is no word like difficult airway. You make it so easily. Know that our total airway will become easy. Actually, only by listening to you, your talk and all this thing. So fantastically, you covered up extensive talk within 30 minutes, so easily and understandably to the postgraduates also. So once again, I congratulate you for your talk and all the things. It is a fantastic talk. I think we have to remember this. So many guidelines. You bring all the guidelines, the guidelines, and what are the drawbacks of the guidelines and all the things also you are told nicely. So my postgraduate will be much more benefited just listening to your talk. So once again, congratulations for your talk. Is a well done. I think extensively well done. So once again, thank you very much. We'll go to the next session, I think, because we are backlog. Dr. B.Jeyarani, she's a anesthesiology in this thing, and she's going to talk on the securing surgical airway. We want to know that how Dr. Jeyarani is going to secure the surgical airway. How far my anesthesiologist and postgraduates we're going to check all this. Once again, we are going back to the Jeyarani for our session. Thank you, Dr. Jeyarani, please.
Sir, good evening, Dr. A.L.M. sir. Good evening, Dr. A.L.M. sir and Dr. Gangadhar sir.
Is somewhere about here?
The
Hello?
topic, sir, am I audible?
Yes, madam. Yes, madam.
Yes.
Good evening, sir. Good evening, Dr. A.L.M. sir and Gangadhar sir.
Thank you, madam.
First of
Thank
all-
you.
First of all, I have to thank my professor, Dr. Meenakshi Sundaram sir, for giving me the wonderful opportunity to speak in front of you all. The topic assigned to me is surgical airway. Surgical airway. Why I have selected this topic means, Dr. A.L.M. I have witnessed 2 cases of percutaneous dilational tracheostomy done in a ICU center. Dr. A.L.M. he only has performed 2 cases, and I have witnessed sir doing FOB in all in our plastic surgery theater. So only I have selected this topic.
What do you know?
What is surgical airway? What is surgical airway? Surgical airway is anything invasive into the airway. Today I am going to discuss in brief about percutaneous dilational cricothyrotomy and percutaneous dilational tracheostomy. And surgical airway. Sir, am I audible, sir?
Yes, madam. Please.
Yes, madam. Yes, madam.
Surgical airway management is needed in every CICV situation. That is in the last part of the difficult airway algorithm. That is cannot intubate and cannot ventilate situation. So surgical airway is needed in at times when there is failure of endotracheal intubation and alternative non-invasive airway techniques have failed. It's the final endpoint in the difficult airway algorithm. Cricothyrotomy and tracheostomy are needed in a patient with airway anatomy and in patients with multiple failed intubation. Cricothyrotomy is a preferred route for emergency airway access. What's the definition of cricothyrotomy? Cricothyrotomy is a technique for providing an opening in the space between anti-inferior border of the thyroid cartilage and anti-superior border of the cricoid cartilage, and the purpose is to gain access into the airway. It's the most accessible part of the respiratory tree below the glottis part. Coming to the classification of cricothyrotomy technique, there are 3 techniques with cricothyrotomy. One is needle technique, that is needle thyroidotomy. Here we are using a needle over the cricothyroid membrane, and it's used for transtracheal catheter ventilation. Next one is percutaneous dilational cricothyrotomy. It's a technique in which incision is made over the cricothyroid membrane, and it's followed by guide wire that is inserted through the cricothyroid membrane, and the cricothyroid space is dilated. Then airway catheter is introduced finally over the dilator threaded over the guide wire. The insertion of an airway internal diameter is larger to allow for ventilation, suctioning, and spontaneous ventilation. Next comes the surgical cricothyrotomy. What are the indications of cricothyrotomy? In case of massive upper airway hemorrhage, in massive regurgitation, in facial traumas like maxillofacial trauma, any structural abnormalities of the airway, both congenital and occurred, and also in case of airway obstruction, both in traumatic and non-traumatic airway obstruction, cricothyrotomy is an indication. For example, in airway edema, foreign body in the airway stenosis, etc. This is the American Society of Anesthesiologists cricothyrotomy airway algorithm. Here we are having both pathways, both emergent and non-emergent pathway. In emergent pathway, the patient will be anesthetized. If the patient is anesthetized, intubation is unsuccessful, patient is unresponsive, but mask ventilation is also inadequate, and the patient is at possible risk for hypoxia. We have to get the help immediately and to attempt the supraglottic method. If it succeeds, no problem. If it fails, means we have to go ahead with the cricothyrotomy. In non-emergent pathway, Here the patient will be anesthetized, unresponsive, no mask ventilation possible, but patient is still maintaining oxygenation. So we can attempt any supraglottic method of laryngoscopy. If it succeeds, means no problem. If it fails, we have to opt with cricothyrotomy. This is the anatomy. This is an anatomy of the cricothyroid space. The first cartilage is the hyoid bone. Next comes the thyroid cartilage. Third comes the cricoid cartilage. Hyoid bone is the highest, is at the highest point. Next comes the thyroid cartilage. It got two lamina which unite acutely in the midline to form a prominence. Why I am telling about all this is the anatomy is so important to identify the cricothyroid membrane. Cricothyroid membrane is nothing but it's between the inferior part of the thyroid cartilage and superior part of the cricoid bone. Cricoid cartilage is the complete cartilage and it encircles whole, but it is widest in the posterior part. So how we can locate the cricothyroid membrane is that we have to feel for the laryngeal prominence. The laryngeal prominence is nothing but the union of two thyroid lamina of thyroid cartilage. It is very acute in case of male, so it's easy to palpate the laryngeal prominence in male. Then comes the membrane. We have to know about the complete anatomy of the cricothyroid membrane because we are going to put incision over there and we are going to put a cannula in the cricothyroid membrane. But this cricothyroidotomy is not recommended in pediatric population. Why is the larynx is underdeveloped and the cartilages are underdeveloped and the fibroelastic tissue are loose in case of children. So it is not recommended in children under 10 years of age and is almost contraindicated in children under 6 years of age. So needle catheter with percutaneous transtracheal ventilation is the preferred method in case of children. So how it is located, the cricothyroid membrane? It is located 2 to 3 centimeters below the laryngeal prominence, as I have already mentioned. The vocal cord, it lies 1 centimeter over the cricothyroid membrane and is not liable to injure in cricothyrotomy. And this cricothyroid membrane has got no overlying muscles, vessels, or nerves, so it's not liable to injure. Now we are going to discuss about the cricothyrotomies. We know the first one is needle cricothyrotomy. Here we are going to place one needle over the cricothyroid membrane, and with the adapter we can oxygenate and ventilate a patient who is in severe respiratory distress. It's done mainly in the emergency settings like emergency ward, ICU, etc. So it's very less invasive and it can be applied in cannot intubate, cannot ventilate situations. So this is the needle placed over the cricothyroid membrane with the syringe, and with the adapter we are going to ventilate with the ventilator bag. These are some of the cricothyrotomy devices we know. One is Cook-Melker cricothyrotomy kit, Portex mini-tract kit, VBM kit tract LAN 2, Portex cricothyrotomy kit. These are the 4 cricothyrotomy kits available, and we are going to discuss in detail about the Melker cricothyrotomy kit. This is a picture depicting the Melker cricothyrotomy kit. It has the components of the kit are one scalpel, syringe, introducer needle, curved dilator, emergency airway access catheter, and airway catheter. So it is available in 3.5, 4, and 6 internal diameter uncuffed airway catheter size with lengths of 3.8, 4.2, and 7.5 centimeters. So percutaneous dilational cricothyrotomy. It's done. It can be done very easily, fast, and it has got few operative and post-operative complications. As I have already told, initial skin incision is made over the cricothyroid membrane. Then guide wire is introduced through the needle or over the needle. So this is a cell technique, which is the reliable and the technique of choice. And the airway catheter is placed over the dilator, which in turn is introduced over the guide wire. So this is the diagram depicting the percutaneous dilational cricothyrotomy. This is the access cricothyroid membrane. With the scalpel, we are making a skin incision, and with the needle introduced, with the syringe, we are confirmed that the needle is inside the trachea with aspiration of air bubbles. Then the syringe is taken out, a guide wire is introduced inside the trachea. Then airway catheter with dilator is introduced, and dilator, guide wire, they are removed, leaving the airway catheter in place. This is a Melker technique which I have discussed in detail. Complications. What are the complications that are associated with this percutaneous cricothyrotomy? There may be difficulty in insertion. Sometimes the procedure may take long, and esophageal and mediastinal displacement leading to emphysema and all, bleeding, displacement of the tube sometimes may happen into mediastinum, causing emphysema, respiratory distress, pneumothorax. So Seldinger technique is associated with minimal bleeding, and it's the most precise technique of insertion. This is third one is surgical cricothyrotomy. These are the components of the surgical cricothyrotomy kit. That is, it's having a dilator, scalpel, forceps, syringe with needle, and some gauge and tracheostomy kit. So this is the contents of cricothyrotomy kit. Trausia dilator, as I have already told, tracheal hook, scalpel with 11 blade, cupped fenestrated, shyly tracheostomy tube, and some sponges, hemostats, and surgical straps. Now we are going to discuss something about the percutaneous dilational tracheostomy. What are the benefits of this percutaneous dilational tracheostomy? The ICU stay is very short. The less requirement of less sedation for the patient, improved patient comfort. I'm comparing with the open tracheostomy. Decreased work of breathing, better laryngeal function, faster weaning from mechanical ventilation, lower risk of ventilator-associated pneumonia, and lower mortality. So nowadays, percutaneous dilational tracheostomy is most preferred than the open tracheostomy technique. It is less invasive, so there is less risk of skin infection. So for critical ill patients, PDT is a procedure of choice for performing elective tracheostomy. As I told, it's cost effective and it can be performed even at the bedside. While cricothyrotomy, it's a procedure that is done mainly in emergency. PDT is done in ICU. That too, it's an elective procedure. These are the some kits that are available to perform PDT. Seldinger guide wire single dilator kit, Siaglia Blue Rhino advanced percutaneous tracheostomy kit, Siaglia Blue Dolphin balloon percutaneous tracheostomy kit, Portex Ultra single stage dilator, Portex Grix percutaneous dilation tracheostomy kit, percutaneous translaryngeal tracheostomy kit. These are some of the PDT kits that are available commercially. So now we can discuss in detail about this percutaneous dilational tracheostomy. It's an alternative surgical tracheostomy. So to do PDT, we have to take the patient history and physical examination, and we have to palpate for the critical landmarks such as cricoid cartilage and neck is inspected fully to for any midline mass or innominate artery. Sir,
No, continue.
Okay, sir. And I have to do the X-ray test to rule out emphysema and hemoglobin PT INR. It should be less than 1.5 to reduce the risk of bleeding. We have to check whether the patient is at risk of bleeding or not. These are some of the indications and contraindications of this dilational tracheostomy. Main indication is to prevent the upper airway damage due to prolonged intubation, that is endotracheal intubation for greater than 7 days, to facilitate pulmonary toilet, and for stable airway in patient requiring long-term mechanical ventilation and oxygenation support. The contraindication is inability to palpate the landmarks such as cricoid and the cricothyroid membrane, any midline mass or a large innominate artery, any uncorrected coagulopathy, it's a main contraindication. In children, it is highly contraindicated, especially those under 6 years of age. If PEEP is greater than 15 cm water, it's contraindicated. And there are also controversies in case of trauma and in obese patients. So Siaglia, he only first performed this technique in 1985, and it's practiced widely in North America. It's an original technique, and it is performed under continuous endoscopic guidance throughout the procedure. A small skin incision is made in the trachea. A small skin incision is made, and a needle is introduced into trachea, and it is sequentially dilated with dilators, and finally the tracheostomy tube will be inserted. This is the tray. So in this Siaglia Blue Rhino G2 tray, so it's having a series of dilators that is displayed here. These are the dilators. They are sequential dilators from 12 French gauge, 18 French gauge, 21 French gauge, 24 French gauge to 28, 32 and 36 French gauge. First is the TFE catheter introducer needle, and there is a J guide wire and dilator, radio opaque TFE dilator we are having, and we are going to dilate it as a whole. So as usual, it's a diagram depicting the whole procedure. That is, with the introductory needle, the skin is pierced. Then with the syringe, the needle inside the trachea is confirmed for aspiration of air bubble. Then the guide wire is left in place, and the wire, the positional marks are marked like guide wire and dilator. Then finally, the dilator, guide wire, they are removed as a unit, and then the tracheostomy tube is placed inside it. So, what are the precautions will you take while performing this PDT? ALM sir, he has done 2 PDT. I have witnessed that. I was with sir in that time. So, a fully equipped difficult airway cart is kept side by, and for a long tracheostomy tube, for extra long tracheostomy tube will be kept for patients who are obese and whose neck circumference is longer. Many kits are available, as I have already noticed. So these are the landmarks. These are the principles to perform this percutaneous dilational tracheostomy. First, positioning. The head should be extended over the neck. The anatomic landmark should be marked. Local infiltration with the 2% lignocaine and 1 lakh solution of epinephrine is infiltrated. 2 fingers breadth below the cricut cartilage. Skin incision was made with 1.5 centimeter size, and curved hemostat was used to separate the tissues. FOB is advanced till its tip is aligned with the lower margin of the endotracheal tube, and the FOB should be connected to a monitor. Introducer needle should be inserted between first and second, or second and third tracheal rings. The middle intercartilaginous placement is confirmed by the bronchoscope. Needle is withdrawn, leaving the catheter sheath through which guide wire can be inserted. Then sheath is removed and it is replaced by the dilator that is advanced over the guide wire. Guide wire catheter, I have already elaborated this in detail. The guide wire, both the guide wire and the catheter form the backbone over which the dilator is used. Then the dilator is replaced by the tracheostomy tube. And ventilatory apparatus is finally connected to the tracheostomy tube. If the ventilation is adequate, the endotracheal tube can be removed. Post-operative X-ray chest should be done to rule out pneumothorax. Accidental, if in case the tube was accidentally decannulated, within 5 days of procedure, we have to re-intubate the patient and never to re-exchange the tube. And the main precautions are, as I have already told, access into the trachea should be confirmed by air bubble aspiration, and the position marks should be maintained throughout the procedure to prevent trauma to the posterior wall of the trachea. Tracheostomy tubes should snugly fit into the dilator for insertion. Siaglia Blue Rhino is the advanced percutaneous tracheostomy kit, and I'm having one video. I'll display it. Curved dilators, I have shown you the series of dilators over that. The main advantage is softness of the dilator, hydrophilic coating of the dilator, one passage technique. This is the video.
Is infiltrated with 1% lidocaine with epinephrine. A 1.5 to 2 centimeter transfer. Just long enough to admit the tracheostomy. Separate the subcutaneous tissues vertically and transversely. Microscope is then inserted moving on a tracheal film. Tracheal wall. The needle is removed, and the 52 thousandths J-tip wire is threaded through the outer. Carrier tracheal wall was expected. The dilator is removed and replaced by the 8 French guiding catheter, which is advanced to the skin level part of the right eye. End of the catheter with the flexible block on the left. Advancement of attraction of the bladder. To verify its integrity, the tracheostomy is the bulk of the foam. Then introduce clinical trachea under direct bronchoscopy.
And the complications of PDT includes both intraoperative and postoperative. Intraoperative complications include hemorrhage, loss of airway or premature extubation, pneumothorax, tracheoesophageal fistula, hypoxia and ventilation problems, hypotension, cardiopulmonary arrest, and recurrent laryngeal nerve injury. Post-operative complications include both early and late. Early includes, as usual, hemorrhage, stromal infection, subcutaneous emphysema, tube obstruction. Late post-op complications include displaced tracheostomy tube granuloma, subglottic stenosis, stromal infection, and tracheocutaneous fistula. Thank you. Thank you, sir.
Thank you very much, Dr. Jarani, madam, professor. Actually, you wonderfully, you secured the surgical area so nicely. I think within 30 minutes, with all the vast experience in your period.
Thank you,
Confidently,
Gangadhar, sir. Thank you, Gangadhar, sir.
even every youngsters supposed to see you and is supposed to know how sturdy you are, how you are there. Number one. Number second, time management. Wonderfully, you manage the time. Usually the 30 minutes. Because normally, as we go become professors, as we become more and more experienced, we are not bothered about the time management. But you so nicely manage the time and secure the surgical airway within 30 minutes is wonderful, madam. Extensively, you covered up things, not only for physiologists, but postgraduates also. If they remember this much, I think it is more than this sufficient for this.
Sir, we are trained by Dr. A.L.M. sir. Yeah, I have worked with sir. Sir,
Yeah,
he
madam.
taught me the basics. He is very strict.
Yeah, I know ALM, sir. I know ALM.
Sir won't compromise. He won't compromise in any aspect, sir.
Yes, madam. Yes, I accepted.
Instead of that,
I also know him very closely, madam. And you are telling sorting also you told ALM sir, and also middle you told ALM sir, and all the things show how much you respect. That thing is your today what you are today is all because of those things, madam.
Sir did so many difficult intubation cases, sir.
Yes.
Yeah, he has done so many difficult airway cases in the OT. He has taught us to how to handle the FOB, how to handle the bronchoscope, and this percutaneous dilational tracheostomy. We have done in 2012, it seems, sir, in ICU.
Yes,
as what textbook thoughts, sir, he taught me a lot.
That's the thing that shows no, madam. How you presented, how you this thing, how nicely and confidence. Not only that, how confidently you are explaining the not only theory, your experience. You are sharing the experience with the knowledge. So that self is a more than sufficient for today's webinar. Our young anesthesiologists and also our experience and so things you will be grateful to. Madam. Wonderful talk. What have we do this one today? Madam, once again, thank you very much for your extensive talk and all that. Not only extensive talk, it is a practical experience you are sparing with us. So that is the most important. It is most important for learning the things rather than the theory and all the things. You told your own experience, 3 decades experience or anything. I don't know. So this is a way. But today's what he called spectators and other things supposed to enjoy this and supposed to remember this and all that supposed to be there. Once again, thank you very much for your wonderful talk. I told you know your time management, madam. Thank you very much. Actually, so most important this. Thank you, madam.
Madam, Dr. Jeyarani, madam, you stop sharing your screen. You stop sharing your screen.
Wait a minute, sir.
No, you click the stop share. You click the stop sharing option.
Sir, click the stop sharing, sir.
Stop sharing. Blue color.
Okay, sir.
Okay, that's nice.
Okay, sir.
So, but moderator, sir, we have 2 questions in the chat box.
Okay, then.
So that is directed to Dr. Yogasathya.
Good evening. There are 2 questions by Dr. Vikram. How to assess the airway in an unconscious patient? This is depends upon the clinical scenario, whether patient is conscious, whether patient is in a hemodynamically stable or not. If the patient is
All
stable,
the others,
you
please
can
switch off
directly.
their mic. Madam, 1 minute. Please
Yes, sir.
mute yourselves. Dr. Munian, you please mute yourself. Please, madam. Yogasathya, madam.
If a patient is clinically stable, hemodynamically stable, that is a different scenario. If patient is clinically unstable, unconscious patient, let's stabilize the hemodynamic stability with the oblique oxygenation. If the patient is hemodynamically stable and patient is unconscious, you just take a rules. I have told already about mnemonics like lemon and moons, rods like that. And then you can do the ultrasound screening. Just do the 3-3-2 rules. Like you can do 3 and 2 rule. We cannot ask the patient to open the mouth in unconscious patient. So you can see the submandibular space, and also any external head and neck abnormalities are there or not. If the patient is unconscious, you should be aware of cervical spine injury. So you can use ultrasound also. This is the basic assessment of airway in an unconscious patient. The management in unconscious patient, you can directly, you can yourself open the mouth by doing the jaw lift. That will help to assess the mobility of the mandibular joint. That's all. The second question is how to secure the airway in an acute maxillofacial trauma patient in intraoral nasopharyngeal bleeding. Actually, this is also same thing. You have to rule out the cervical spine injury, and also you have to, if the video laryngoscope is available, you can do the video laryngoscope without doing neck extension and all. And one more point is here, you can use suction catheter. And also Yonkers suction is very useful in case of profuse bleeding. And in meantime, you have to call the ENT surgeon, or you have to be ready with the surgical airway management. So while doing the scopy, you have to keep this suction catheter in the same hand with the laryngoscope blade, so it will clear up your secretions and you can view somewhat your epiglottis or vocal cord. Then you can do the intubation if possible, and don't forget to put suction in the ET tube after intubation, because more chances of aspiration in the ET tube. So be aware of that. Next question is by Dr. Mukesh. How to assess and approach the difficult airway in a morbid obesity patient? I have shown one slide about morbid obesity. The ramping is very important, but it is not possible in case of trauma care. That is in ED department, it is not possible, but you can head up position is very important. And most of the obese patients will have OSA, so you cannot mask ventilate the patient that much easily. So use oropharyngeal or nasopharyngeal airway and try to mask ventilate the patient adequately to avoid the rapid desaturation or refractory hypoxemia, and continue the nasal catheter or nasal prongs to give the oxygenation, and then go for your available devices like a McCoy blade or video laryngoscope or FOB incision. Anything is available according to your trained method. You can go for a intubation or any other help. Thank you, sir.
Madam, I got one question.
Yes,
For
sir.
particular location, what's that? Sir, I got a question
Sir?
to Dr. Yogi, this one. Sir, you are in
Yes,
a
sir.
remote location, actually, with a
Okay, sir.
limited airway equipment, and patient
Yes,
has a
sir.
known airway. How do you
Yes.
modify the madam? It is the benefit of the
Non-difficult airway. May I
known
correct, sir?
difficulty.
Non-difficult airway.
Yeah, madam.
Modify the approach. Yeah.
Madam, I'm repeating the question. You are in a remote location with a
Yes, sir.
limited this one. How do you modify
Okay,
that?
sir. Okay, so in a remote location, actually we have to go for a awake intubation, sir. With, if possible, we can put a airway blocks to abolish the airway reflexes, or you can spray the 10% lignocaine spray, and we can ask the patient to gargle, or if you can go for a blind nasal intubation or awake intubation with abolished airway reflexes, sir. It is better
sorry to intervene, sir, moderator, sir. See, this is not the way. So the speaker should have asked whether it is elective surgery or emergency surgery. Sir is very clear. Sir is very clear.
Okay.
Limited infrastructure, known difficult airway. He says known difficult airway. Then
Yes.
you are not supposed to attempt. That is my why you venture. Why you venture with awake intubation? That is wrong one. So in my personal opinion, you should not do that.
Okay. Okay.
Because people should not take a wrong message. Another one, spraying with the 10% lignocaine is not at all needed. You have to spray with the 4% lignocaine only. 10% is topical for skin. So for this spray, 10% means then the dose may exceed. So even then, in a limited, he is repeating, sir is repeating, remote location, limited infrastructure, please don't venture. Don't venture with the airway. You will lose the patient on the table.
Exactly.
Request. Junior, be very
For
Thank you,
our
sir.
generation, and this is a question for the young generation. Actually,
Mm.
what that is my intention. That's all, the madam. How to
Okay,
apply.
sir.
I think Dr. Elam has answered fantastically, and he clarified the doubts so nicely for our young generation. I think they should not make any attempt at the junction. Actually, if you made any attempt, actually it is a disaster. No doubt about it. Okay, madam. Thank you, madam. Thank you very much for
Thank you.
your
Thank you.
kind. This one will be there. Uh, any questions
No,
from the
sir.
audience?
Two she has answered. See, she has answered, sir.
Okay, sir. Okay.
So if there are no questions, we can go for wind-up discussions. If moderator wants to have any wind-up message, sir can tell, or else we can go for.
Sir, we can go.
Yeah, thank you very much, sir. Thank you very much. So now I have a mixed feeling in this webinar. First, throughout the country, I was regarded as a person with a sense of humor, jovial orator. I will be cracking jokes. So just because the people are from my place, they started saying that I am strict, I am very perfect. So they are showing my other side of the coin, which other people may not have known, because now I recollect one incident when I was Dean Thiruvarur Medical College, Dr. Tarlika Parimal from Gujarat. She came as a chief guest for our Ether Day function, World Anesthesia Day. And at that time, she said in Hindi, Sar ko naraz hoke main kabhi nahi dekha. Meaning, I have not seen Sir in an angry mood at any point of time. Then everyone laughed because they said, we have never seen him in a happy mood at any point of time. So that is a big news for Dr. Tarlika Parimal. So now the same thing has happened. But as she is affectionate, she wants to show her regard to the teacher. So Dr. Jeyarani remarked many times. But again, I want to tell one point. In percutaneous dilatational tracheostomy, I have never used graded dilators. I was using a Percutist brand, Percutist by Rush. It is having a single dilator with a guide wire. They have technically manufactured it. Once you dilate the stoma over the guide wire will get twisted. You cannot reuse it. So every time, at that time itself, it cost 23,000 rupees. Now I don't know what is the price of that. And she has repeatedly said, Sir has done it twice. To be honest, I have done plenty of times. She has seen two times. But what I want to convey to the youngsters, please, percutaneous dilatational tracheostomy cannot be done under local anesthesia. Not at all possible. So you may not have a chance to do that. It is not an emergency airway securing procedure. No. So the what I personally feel, if the patient is already intubated, like she said, 3 days ventilation or 6 days ventilation, if already intubated, the general anesthesia, at the level of general anesthesia only, we can do that in ICU. Because the cannulating, that is by introducing a IV cannula in the cricothyroid membrane, that will be easy, and the tracheal ring, it is very easy. But at the time of dilatation, as I was practicing only single dilator, see, the pressure and the trachea will be phenomenal. It cannot be done under local anesthesia. So, but the best advantage of PDT is you can do it at 2 and 3 rings between 2. Usually surgical tracheostomy is done lower down. This, and the best point is it can be secured in a higher way. Another one, it is not, we are not going to cut to the tracheal cartilage. We are only dividing it. So the incidence of tracheal stricture is very, very minimal with PDT. And in single stage only, this is the advantage. In graded dilator set, you may need a tracheal dilator. So you have to dilate that, but in a single dilator set, even that is not needed. But it require deep level of sedation or anesthesia, preferably, and the patient under ventilation, artificial ventilation. That is academic part. Non-academic part, I want to say, this is the first time I have counted the message, 52 messages I received, that they are finding it very difficult to log in. That is the reason why we have given. This is for ClickNet people, I am saying. See, many people, Dr. Singla from Medanta Medicity, Dr. Mandeep Singh from Medanta Medicity, Dr. Shrikanta Oak from Nagpur, Dr. Kripagaran, our Tamilnadu president, Dr. Muthukumar from Coimbatore, Dr. Narmada Yangse from Coimbatore. Plenty of message I received. There is a difficulty in joining. So I talked to the ClearNet people and I said, we cannot offer any more excuses. See, I was happy when I'm receiving so many messages. People are waiting in pipeline to join. So our webinar has gone into the minds of the people. But if they are frustrated like this, because I have received 3 messages, sir, every time this is happening, this is the 4th time we are finding it very difficult to log in. And the ClearNet person wanted me to send a message about the problems faced, but I want to go on record so that Shreyasi is available here. She have to pass on the message. See, we are doing for a good cause. So if it is not reaching the masses, then it will go absolutely as a waste, because I should not be frustrated as an organizer. And the ClearNet, they are doing it as a scientific platform. Even they should not be get frustrated because of this. This time, it is phenomenal. Because once I finished my thing, just I have taken the phone, continuous messages were there. And they are asking, sir, what is happening? Sir, please send the screenshot. See, it is very difficult. All are learned people. All are qualified people. They know how to behave. They will switch off the mic, I said. But today, I have seen 2 people have not switched off their mics. So when other person is talking, we have to switch off our mic. So that basic decency, courtesy, every people will follow. So I request the ClearNet people next time, please allow the people to join with the speaker mode. If they could not join with attendee link, allow them to join, because they say the number will increase, then a lot of extra noises will come. It will not come. We will even say, even when somebody is talking, we will inform them. I request the ClearNet, please consider this, and I will put up an official message also. And I regret for the people who have not joined, who are not able to join, because morally I am responsible for whatever is happening as an academic coordinator. Sorry for the inconvenience. Thanks, ClearNet. And before we end up, I request Dr. Hema to propose formal vote of thanks.
Good evening, sir. Good evening, everyone. On behalf of ISA Puthukkottai, I'd like to thank all the participants for your continuous support. Thank you, our academic chairman, Dr. A.L.M. sir, for guiding us and enlightening us on today's very important topic on airway management. Thank you, Dr. Raghuvaran, postgraduate Tamilnadu, Thanjavur Medical College, on your presentation on Mallambatti classification. I thank Dr. Yogasathya, Assistant Professor, Thanjavur Medical College, for the wonderful videography and detailed presentation on today's difficult airway guidelines. It was very useful for the post-graduation as well as refreshing for the practitioners also. Thank you, Dr. B.Jeyarani, Professor, Tamilnadu, Thanjavur Medical College, on securing surgical airway. It was very experienced and detailed presentation. I thank our moderator, Dr. Gangadhar sir, HOD, Professor, Siddhartha Medical College, Tumkur, for your guidance on today's presentation. Thank you, ClearNet, for your continuous support. Thank you all the participants for the continuous support and attendance shown in the previous webinar sessions. Thank you all for this wonderful evening. Thank you.
Over to ClearNet.
Thank you, ma'am. Thank you, Meenakshi sir. Thank you so much, everyone, for giving us the opportunity to host the session. So with this, we are concluding the session of IR for today. Thank you. Good night to all of you.
Thank you very much.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you, sir.
Okay.